Okay, hello everybody. Welcome to part 2 of the IMV Imaging Journal Club. Thank you everybody for joining us tonight. Just so you're aware of the format, this is sort of part 2 of our journal club. We had one edition last week and then we had another this week. This was based on Laura's critically appraised topic on what's new in equine foot radiography. There were so many papers that we had to split it into 2 parts. So last week, hopefully if you joined us, you saw the parts dealing with the kind of radiography. And this week we've been looking at more the radiological aspects that were brought up in the paper. So just to introduce everybody, I'm Sam. We've got my colleague Laura and my colleague Hannah. We're both all part of the vets, part of the team here at IMV. So we'll get started looking at everybody's questions. Hopefully everybody watched Laura's presentation earlier this week and we can follow up on those questions that everybody sent in, and thank you very much for sending them. So just starting off, the first kind of comment we got in is from somebody was that they thought the comments regarding the lack of need for a dorsal hoof wall marker was interesting, and that they agreed that radiographs that are suitably exposed allow you to easily determine the outline of the hoof wall and the layers of the hoof wall. But they were mentioning that they do commonly use a hoof wall marker to accurately determine where the edge of the coronary band is in the radiograph for measuring founder distance, and just wanted an opinion on would we still be using the marker in this instance, given what was sort of brought up by the papers about possibly not needing one if the radiographs are done at a kind of correct exposure.
I think that generally with correct exposures where you've got really nice soft tissue contrast and visibility, the coronary band should be visible or easily identified on the radiographs. Although sometimes I probably do agree that it is difficult to locate exactly where the coronary band is for whatever reason. So yeah, I think in that instance, that would be a really good reason to use some sort of radiopaque marker. The one thing that I think about radiopaque markers is that we're usually using some sort of piece of metal, because that's nicely radiopaque. You can see it really clearly on radiographs. The one thing I'd say that if you use a marker along the entire length of the dorsal hoof wall, in addition to usually positioning it at the level of the coronary band, so you get 2 bits of information at once, you get an artifact on digital radiographs called Überschwinge. So it's like an edge artifact. So it's a dark halo around anything that's very radiodense, like a dorsal hoof wall marker. So if you were using that to identify where the coronary band is, and also using it to measure the hoof wall to distal phalanx distance, I would just be aware that when you do have Überschwinge, you're therefore you won't be able to see the dorsal hoof wall in addition to the marker, and so accuracy of the measurement would rely on having that marker really closely opposed to the dorsal hoof wall. And if you have a horse where the hoof wall is undulating, which sometimes does happen in horses with hoof wall thickness abnormalities, getting an accurate measurement may therefore not be possible. So I think, yeah, radiopaque markers certainly can be useful for identifying the coronary band, making it really nicely and clear where it is. But I think I would be cautious about using a dorsal hoof wall marker in place of a well-exposed radiograph.
Would you also kind of, because I use them in practice, I must say, but they also the consistency of placement of where it is on that dorsal hoof wall, like, you know, that's obviously maybe something we've also got to be, if they are going to get used, and maybe confident in getting a good exposure there is there until you've got that confidence, maybe again.
Yeah, you're right. If you're using something that's very thick and you position it not exactly dorsally but slightly dorsal medial or dorsolaterally, then yeah, you would run the risk of essentially on the radiograph it would make the hoof wall look thinner than it actually is. So you do have to be quite careful, like you said, with placement of that marker. But yeah, I mean, yeah, choosing exposure values is, I think many people find it difficult. I certainly used to find it difficult. It's something that I think many of us as vets are not very well practiced at, even though we're doing it all the time. So, I mean, one would hope that for every piece of equipment, the exposure factors required are different. And so most practices will have an exposure chart, which hopefully has been optimized. But that said, they're not always perfect. So I think being critical of it is important.
Yeah, I agree with you. And actually also in practice, you know, sometimes if you're in a larger practice and you've got multiple generators and multiple pieces of like maybe DR kit or kind of CR kit, those exposures are going to change depending on what combination of generator and plate you've got. And I don't know how, I definitely didn't understand that when I was in practice. And so your exposure settings that you've got for one combination might not be the same. And I must say, I think that's something to be aware of when you're doing, to try and get that consistency, that difference in equipment will actually potentially affect those exposure charts that you're kind of using.
Yeah, no, it's really good points about the equipment. I mean, I think if you have the luxury of sort of having a DR system that you can use to sort of see the image quality, it makes it a little bit easier than if you're sort of limited to a limited number of plates, especially if you're not in the hospital as well. You've only got a sort of a finite number of kind of shots you can take, will maybe have an impact on how you decide to kind of mark things really as well, if you're maybe not able to be as certain about your exposure factor. Good. Okay, cool. We'll move on. So the next question that we had kind of sent in was, should hoof wall to distal phalanx distance ratios be used following clinical signs, sort of, or on every hoof radiograph? So I think this was more probably making it, should the hoof wall to distal phalanx distance ratio be used specifically in laminitis, or is it something that could prove useful in other conditions?
I think absolutely yes. If there are any indications of laminitis, either radiographically, also other radiological indicators, or a horse with clinical signs of laminitis, or a horse that is likely to be predisposed to laminitis based on breed, they're overweight, or they're older, might have PPID, then yeah, I think measuring hoof wall distal phalanx distance is definitely indicated. But I think even in those horses without other signs of laminitis, or even things that we would generally consider as predisposing factors to laminitis, I think it's still important that we evaluate the thickness of the hoof wall and the hoof wall itself. I certainly think that in sports horses, and a lot of, for example, dressage horses, I think subclinical or atypical laminitis is underdiagnosed. And I've seen quite a lot of horses where the only radiological and clinical sign is the fact that these horses have a thick hoof wall or hoof wall to distal phalanx distance ratio on radiography. And in a lot of those horses that then go to MRI, then there is increased signal intensity in fat suppressed images around the periphery of the laminae as they attach onto the distal phalanx. So there's no sort of scientific research into this at the moment. I think it's something that really should be done, but I do think we underestimate the prevalence of laminar pathology rather than just acute laminitis in the general horse population. So I would say it should always be evaluated. That said, I think the more you'll get used to looking at hoof wall distal phalanx distance, you get your eye a little bit attuned. So you get to the stage where you can look at a radiograph and you think, oh, that looks like it could be thick, or definitely is thick, I'm going to measure it. Versus sometimes you can look at a radiograph and you can confidently say, it's not thick, that looks completely normal, I don't need to actually take the measurement. So I don't think necessarily taking the measurement every single time is necessary, but certainly assessing, is the hoof wall thicker than it should be? And also, is the regularity of thickness equal from proximal to distal? So is it thicker distally versus proximally, for example?
Okay, great. Excellent. And then the next question we had sort of in was somebody referring specifically to the paper authored by Mullard, was there a normal range of hoof wall thickness documented in addition to the just looking at the hoof wall to distal phalanx distance ratios? So did they put a figure or a range for hoof wall thickness in that paper?
So they did document the thickness in millimeters versus the ratio, and I'll just share my screen so you can see the paper. So just looking at table 2, this table presents the thickness of the hoof wall in millimeters, so this isn't the ratio. And so they did present it. Now, with regards to a normal range of thicknesses, it's the same kind of thing that applies to the normal range of ratios that they documented. So the range and sort of the means and standard deviations that they report in this table and also throughout the paper are somewhat limited by the population or the normality of the population. So none of these horses had clinical evidence of laminitis or a history of laminitis, and none of them had known equine metabolic syndrome or pituitary pars intermedia dysfunction. However, it doesn't necessarily mean that all of the horses were completely normal with regards to the lamellae. So some of these horses may have had laminar pathology despite not having acute laminitis or a history of acute laminitis. So I think the normality of the range is somewhat limited by that, because I think ideally to get a truly normal range, you would need to do this kind of study in a population of horses that also underwent MRI or histopathology, so that you could more confidently say these horses didn't have laminar pathology, these are the normal ranges that we found. So the study was limited by the population, and certainly there was evidence, if we just scroll up, that some of the horses may well have had laminar pathology. So looking at figure 3 on the left hand side, these are just a couple of examples where they've shown that there's modelling on the dorsal mid aspect of the distal phalanx in these 2 horses. So this is something that we would be considering could be associated with laminar pathology. So it's relatively likely that at least some of these horses did have perhaps subclinical or atypical laminitis. So exactly how normal the ranges are, well, I think we can't rely on them entirely at this stage. So again, it's I seem to say it a lot, but we do kind of need more research here.
Yeah, that's okay. I think looking at a lot of these papers, there's lots of interesting kind of bits, but maybe not a lot of stuff you could confidently sort of take forward to sort of say, well, this is definitely going to apply to a larger population, or kind of in a lot of different scenarios as well. Just sort of talking about that, sort of looking at hoof walls and things, that was sort of the next question that came out is what was our thoughts on using hoof wall thickness alone as an indicator of P3 distal phalanx rotation?
I think they probably come somewhat hand in hand. So with rotation, inevitably there's going to be some increased distance, or at least increased distance distally compared with proximally. So I think I wouldn't use one in isolation of the other. I think if you have evidence of one, then you should definitely be looking at the other independently. I think, and you can also have rotation potentially without increased hoof wall distal phalanx distance ratios, at least in some parts of the hoof wall. Equally, you can have increased thickness without distal phalanx rotation. And they did, just looking back at the screen, I've just highlighted this one paragraph here. They did find that when they looked at the hoof wall distal phalanx distance in millimeters, so this isn't as a ratio, in quite a lot of horses, so 60% had, of all these feet, horses which had the middle measurement, which was just about here on the radiograph, was greater than the proximal measurement, then the hoof wall distal phalanx distance ratio was greater than 0.25. So we're thinking, is this abnormal? And again, when the distal measurement, which is right down at the toe, was greater than the most proximal, again, 43% of horses had a potentially abnormal ratio. And in horses where the distal measurement at the toe was greater than mid measurement, again, slightly less, but 35% had over 0.25 ratio. So again, that is a potential indicator that it was abnormal. So they did allude in the paper to the fact that in some of these horses, there may well have been rotation of the distal phalanx in addition to increased hoof wall distal phalanx distance. So I think I would say look at both independently and together.
Okay, well, excellent. And then finally, on the questions, we had somebody ask, why was the height of withers used to correlate with hoof wall to distal phalanx distance in ponies? So I think that was referring to the paper that was looking at the kind of hoof wall sort of measurements in ponies specifically.
Yeah, I've got that paper up as well, so we'll just flick over there. So we're just looking at their table 3 at the moment. So this table shows, it's a bit difficult to know based on all of this exactly what they all mean, but these are all the parameters and measurements, both linear and angular, that were potentially correlated with height of pony. And here they've got their sort of Pearson's correlation coefficient value and means, but also they've got a value of how much something will increase per 1 centimetre increase in wither height. So looking at the hoof wall to distal phalanx distance, they've done it for proximal and also the distal hoof wall. And for both of them, I just highlighted one of them here, for every 1 centimetre taller a pony is in comparison to one that is 120 centimetres, which is the standard for this, there's going to be a 1 millimetre increase in that thickness. So it's a relatively small change, but they did correlate it significantly, that the greater the height of the pony, the thicker the hoof wall is going to be. They did look at height to body weight ratio in the Mullard paper, and that was negatively correlated to hoof wall distal phalanx ratio, but they didn't assess the body condition score. So using the height to body weight ratio, it's hard to say exactly what the effect of the height was. But certainly in this paper on the ponies, it appeared that for every 1 centimetre taller than 120 the pony is, it's going to go up by about 1 millimetre. So small, but it was significant in their paper.
Okay, that's great. Excellent. Well, that's actually a run through of all the kind of questions we got in. I don't know if you guys had any other kind of comments or anything you wanted to mention following the papers or following up with anybody else had said.
Well, one of the things when I was looking at it on the Zani et al. Kind of paper, they do talk about the quality of the radiographs, essentially. Well, you kind of allude to it, Laura. What would you say is a good kind of protocol when you're kind of assessing an X-ray to say that, yeah, that's a good one, or no, actually, we probably need to retake? What would the kind of key areas you look?
Well, they looked at primarily lateromedial radiograph, which I think are, I mean, everyone, no matter what protocol you're using, a lateromedial is going to feature. It's one of the most important views, really. But I also think it's potentially one of the most difficult to get right. And certainly that's my experience, because a slight obliquity of angle in the foot relative to the generator, you can end up with a radiograph that is not particularly great quality. I think generally, well, of course, getting exposure values right. So you want to have good definition of the cortex and the medulla, and you want to be getting enough penetration that you don't have quantum mottle. So if you don't have enough MAS, then you tend to get this sort of grainy appearance through the bones, especially wherever the bone is thickest or largest, you get this mottled appearance. So you want to have good, or it obscures the trabecular pattern and fine detail. So you want to have enough penetration that you're getting through that and you can see the trabecular pattern really nicely. But equally, you want to be able to see the soft tissues. In this instance, the hoof wall, basically. So that would be the first thing to look at. I think secondly, you want the condyles of the middle phalanx to be superimposed. So you want them to be sort of level with each other rather than being able to see two at the same time. And I think the third thing, which I think is actually key to getting a good lateral medial radiograph, is that the palmar compact bone or the flexor cortex of the navicular bone should be superimposed.
Mm-hmm.
So if you look at that that palmar compact bone, it should, in a normal horse, it should be a really well-defined, distinct radiopaque line, and you should be able to see the sagittal ridge behind it. If you have slight obliquity between the navicular bone and the beam, then you don't get that superimposition. If you do it, if you have quite a lot of obliquity, you won't be able to see the sagittal ridge poking out the back, but also you'll see two distinct lines rather than one distinct line.
Mm-hmm.
And the problem with that is then you can't assess the thickness of the palmar compact bone, which is important. And that's something that they showed in the paper, that a thick palmar compact bone can be correlated with significant injuries. And you also can't assess the clarity of margination between the flexor cortex and the medulla, because you've got that obliquity. It makes it look thickened, and it can make it look like you've got really poor compactospongious demarcation, even when you might not. So you can, with even just like 2 or 3 degrees obliquity, make a normal navicular bone look really quite abnormal. So just making sure you've got that being really perpendicular to the navicular bone. If you haven't and you've got that slight obliquity, then just make sure the foot is straight, that your beam is parallel to the heel bulbs. And if you're still thinking, well, it looks fine from the outside, I can't tell what's going on, or why I'm not perpendicular, and what I tend to do is angle 3 degrees from dorsal, see what happens. If it gets better, great. If it doesn't, go through palmar. Okay. And just keep going like that. So usually if you do that little 3 degrees trick, if you're really not sure which way you're oblique, then it usually does work out. And if one, for example, doing 3 degrees from dorsal improves it, but it's still not quite there, you might need to add another couple of degrees just to get it right.
Well, they're really good. Yeah, I like that kind of like that nice kind of like checklist to kind of go through, as I say. And the more you do those kind of checklists, the more it just kind of comes habit. And as you said, a bit like as you're talking about the thickness of the dorsal hoof wall, you just get your eye in, and you know it becomes a lot easier as such. The other thing from that paper as well, like they talk about the inconsistency in that particular paper of the nomenclatures for things, and it was more kind of amusing, I suppose, than a point. But I've found this before, sometimes looking at papers to do with equine cardiology, that we don't have a consistency there of where the measurements are from or to, or what we're calling things. So actually being able to kind of look at multiple papers from multiple different places becomes quite difficult to compare the two, and whether actually we probably need to move towards getting an industry standard that this is the kind of the criteria that we use, and that we're all using the same words essentially. So yeah, that was just another kind of bit amusing as such.
Yeah, it happens. It's very typical also of use of the AAEP scale for grading lameness. It's another common one that crops up. If you look at the definitions of the AAEP scale, you can tell automatically that most people who use that scale don't actually follow it word for word, because it's very, very specific, to the point where you think actually this is not particularly user friendly or usable. So anyone who says in a paper, oh, we use the AAP scale, and you actually read how they use it, you think, well, you probably didn't, did you? So So
Needs to
yeah,
be user-friendly as well as, you know, standardized.
yeah, it's like, it's, you know, that they're saying it's the AAP scale because it's one, like, but what I think they really mean is we did 1 to 10 or 1 to 5. But yeah, recurring issues.
Keep battling away. I think it's always the difficult thing, isn't it? How do we unify? Who has the say on how we're actually going to do it? And, you know.
Yeah, who makes the consensus, I think, is always a difficult question.
Yeah. We'll
I mean,
keep on trying.
it would be the dream to have an industry standard on radiography that everyone sort of agrees on, that there's a consensus, and that's what we do. But it's a lot of it's open to interpretation currently.
Great. Well, there's some really fantastic points and some brilliant tips there, just with regards to this radiography and radiology of the hoof as well. So I think that's all our questions. So I think it's a good time to end. Thank you, everybody, for joining us. It was really great to see everybody and get everybody's questions in. We really appreciate it because we couldn't have these sessions without everybody joining in for it. If anybody does have any questions kind of following this, you can always get in touch with us at the hello@imv-imaging.com email address. And if you keep an eye out on our social media pages and our newsletter, you can see often a link to where we'll put the recordings of our journal club meetings up as well from there. And definitely stay on the lookout for future journal clubs. And over the next couple of weeks, we've got a lot more webinars and also some episodes from the journal club archive coming out to everybody. So hopefully there's something there to interest everybody. And if you keep an eye out in the future, you can also look out for future meetings where you can get involved in. So I think after that we can say goodbye and hope everyone has a good week. Okay, bye-bye.
Thanks everyone, bye.